Hi everyone, welcome back to my channel Mastering Anesthesia, where we will discuss about critical topics in anesthesia, making them easy to remember and easy to understand. Make sure you watch this video until the very end. There will be special visuals, there will be explanations, all for you to understand it better. So let's go! Let's talk about Suxamethonium, or the other name is succinylcholine. They are basically two molecules of acetylcholine joined together by acetyl groups. They are dicholine ester of succinic acid. To understand this, we have to recap on the structure of acetylcholine. To draw acetylcholine, start with CH3, CO, O, 2 CH2s with N plus and 3 CH3s. This is the structure of acetylcholine. Therefore, suxamethonium is basically 2 of acetylcholine. Start with CH2, you have CO, and then you have 2 CH2s, and N plus with 3 CH3s. Now this is one structure of acetylcholine. We have to join this with another acetylcholine by its acetyl group. We have another one here of CH2 connected with CO, O, CH2, remember there are 2 CH2s, N plus, and 3 CH3s. And there you go, you have your structure of suxamethonium. Remember that the structure is similar to acetylcholine. Therefore, the positively charged N plus imparts an affinity towards the nicotinic acetylcholine receptor, causing an action potential. Comparing with the actual acetylcholine, suxamethonium only needs to bind to one binding site of acetylcholine receptor to generate action potential. Meanwhile, acetylcholine needs to bind to both the binding sites on acetylcholine receptor in order to generate action potential. Let's talk about the mechanism of action. So unlike acetylcholine, remember that the suxamethonium are not metabolized by acetylcholinesterase at the neuromuscular junction. So their concentration reduces very slowly compared to acetylcholine. What this does, it causes prolonged end-plate depolarization. So the question arises, how does depolarization causes muscle relaxation? The continuous end-plate depolarization causes the perijunctional voltage-gated sodium channels to open. However, they are time limited as well, so therefore they rapidly closes or deactivates following depolarization and cannot reopen unless the membrane repolarizes. So let's visualize it so that we understand it further. Here we have the terminal axons, the motor end plate. Here we have acetylcholine vesicles releasing the acetylcholine into the synaptic cleft, the receptors, the acetylcholinesterases, your perijunctional voltage-gated sodium channels. So acetylcholine binds and activates the acetylcholine receptors, propagates it to the perijunctional voltage-gated sodium channels, and propagates the action potential. What happens when we introduce suxamethonium? It binds either to both active sites or one active site of the acetylcholine receptor, causes depolarization, and they are prolonged because they are not metabolized by the acetylcholinesterases. The perijunctional voltage-gated sodium channels play a crucial role in the relaxation of the muscles in depolarizing muscle blockade. So you have three configurations. The first configuration is when the upper gate is closed and the lower gate is opened. When the membrane depolarizes, both the upper gate and lower gate opens, causing sodium to flow in and propagates the action potential. Next, the third configuration is when the upper gate remains open and the lower gate closes because it is time gated. Regardless of what happens, it will close. And in order for it to get back to its original resting condition or configuration A, it has to repolarize. So if we simulate the acetylcholine receptor getting activated by suxamethonium causing depolarization, will cause a configurational change in the voltage gated sodium channel. You can see the upper gate will open following depolarization. Next, the time-gated sodium channel will automatically close, preventing further propagation of action potential. And in order for it to get back to its original configuration, it has to repolarize, which cannot happen because suxamethonium is still bound to the acetylcholine and continuous depolarization occurs. All in all, the prolonged binding of suxamethonium to acetylcholine receptors causes muscle relaxation. The effect is prolonged because they are not metabolized in the neuromuscular junction. It has to diffuse into the blood and then it will get metabolized by pseudocholinesterase into succinic acid and choline. When question arises as to describe suxamethonium, so we have to have a structured answer. We have to talk about the structure, the uses, the ADME, the absorption, distribution, metabolism, excretion, the drug dosage. First, for its presentation, remember, it is odorless, it is colorless, it is stored at 2 to 6 degrees Celsius in 2 mils ampules at a dosage of 50 mg per ml and used at a dose of 1 to 2 mg per kilogram. It is used in RSI, short procedures, and altering seizure activity, especially in ECTs. Moving on to the kinetics, they are rapidly hydrolyzed by plasma cholinesterase or pseudocholinesterase, which can be found in plasma and liver. They are not found in neuromuscular junction. Only about 20% of the administered suxamethonium reaches the neuromuscular junction, and due to its rapid hydrolysis, only less than 10% are excreted in the urine. As for its metabolism, suxamethonium succinylcholine will be hydrolyzed by pseudocholinesterase into succinylmonocholine and choline. The succinylmonocholine is a weakly active substance, which will be further degraded into succinic acid and choline. Now, what are the effects of suxamethonium? Remember, there are 8 points. Number 1 being the most commonest is myalgia, especially most in young females. You can help alleviate the symptom by giving non-depolarizing muscle relaxant, dantrolene, diazepam, and NSAIDs. Next is arrhythmias. Commonly seen are bradycardia and ventricular arrhythmias. How they come about is because of the stimulation of the muscarinic receptors found in the sinoatrial node. Now, the bradycardia are more pronounced in pediatric population, also following a large second dose of suxamethonium. The next effect is hyperkalemia, which we must not forget. Normally, there will be a small transient rise of about 0.5 millimole of serum potassium in normal individuals. However, it can be more prominent and unpredictable in some certain group populations, such as those with more than 10% burns after 24 hours and less than 18 months, those with neuromuscular disorders, those who are paraplegic, those with progressive muscle disease, and those who are, had trauma-induced immobility. Then you have also increase in intraocular pressure, which can be significant in global perforation. You have intragastric pressure can increase from suxamethonium about 10 centimeter water, but it is offset by increase in the lower esophageal sphincter tone. Therefore, there is no increased risk of aspiration. Then also you have the risk of anaphylaxis, which is about 2 to 3 times more likely to cause anaphylaxis by the use of suxamethonium. Then you have Suxamethonium apnea or Sux apnea, which basically is a prolonged neuromuscular block. And lastly, it's the malignant hyperthermia. Well, there you go. Thank you for watching this video. Next, we're going to talk about Suxapnea, malignant hyperthermia, trainer 4. Please stay tuned. Please subscribe, like, and comment down below. See you in my next video.